So any questions from the audience? No questions? Jesse.
Well, I think it's a great session, very, very important session. I think this topic is neglected for a long time, and I think it's about time, because most of the big pharma company really don't like to deal with kids. They really try to postpone it. And I have some experience in Italy, for example, with Doxil. Many of the, Doxil were never approved for kids. But in Italy, many of the physicians, at least a few years ago, I was invited in a meeting, and they use Doxil for kids. And there are now a lot of data show that even for blood tumors, Doxil at least is not inferior, at least not inferior, and in some cases maybe a little bit superior to the regular drug, but the main benefit is that there are no all these major side effects that you see in kids, which really prevent them to go to school, alopecia, all these problems, the fact that they look so different, the other kids afraid of them, all these kind of things are much less pronounced. And the Italian physicians, at least the ones I talked with, they said they feel it's, they don't understand why people doesn't take advantage of it and try to prove better that first these drugs are not less good than the normal drug and have a lot of advantages in patient compliance, which is, I think, these kids' compliance is really a very major issue. And really maybe study if it's better. And I think, I really feel very bad that this was not done and still not done. You talk with things, they said, leave us alone. We don't want to go into this minefield at all.
I think that Angel can comment on that. We were discussing yesterday that Doxil and Abraxane are now having some impulse trying to undergo clinical trials in children.
Studied, so they just gave up Doxil. With Abraxane, I can tell you there are very interesting results of the phase 1-2 trials in children in Europe. They can achieve very high dose of the drug, safe dose, as compared to adults. So children can receive a higher dose than the adults safely. That's important. So that's one of the differences that Alejandro mentioned before. Children are not small adults, and in this case, they can get higher doses as compared to adults. And also in preclinical models of especially sarcomas, there are very good results with Abraxane. So this is now going to the children as well in clinical trials, in well-regulated clinical trials. So I would say the new nanomedicines have a much better way to the clinic as compared maybe to the old days with Doxil. The new ones have more chances to succeed. Abraxane is probably one of the examples. I'm very excited about the results we are getting with the preclinical sarcoma models. It is very active in 50% of the PDX models. This is published already in the St. Jude group, and we are validating it in our hospital. So there's a lot of future for that drug, for example.
So I read one paper, and what I know about cancer nanomedicine can be written on the back of a very small postage stamp. But I read one paper which said I think there's 9 of the nanocarrier type anti-cancer agents which are now in development or clinical trials for childhood cancers. So I think I guess that's quite encouraging in the context of this discussion too.
It is. Actually, I think there is a program to support the use of these new nanomedicines in children, right? The PIP, the Pediatric Investigation Plan, so they promote with specific regulatory rules the translation of these new drugs to children, providing advantages to the companies. I think they get like 6 months more patent or something like that after they do the clinical trial in children. That's very important for to encourage the companies to do the clinical trials with children.
Any other question? Yes.
My question is to Dr. Engel. So what is the percentage of drug which crosses the blood-brain barrier, while we keeping in mind that the blood-brain barrier is intact in pediatric cases?
So that's a really good question. Obviously, it's drug specific. I think there's 28 antiretrovirals now which are licensed for use. There's been a lot of work done on CNS penetration of antiretrovirals because it's thought to be a sanctuary site for the virus. There's comparatively little data, though, on penetration across the blood-brain barrier. So the CNS work which has been done has been predominantly done on CSF. And as you know, the drug doesn't need to go across the blood-brain barrier in order to get into CSF. So how good a surrogate that is for brain, who knows. But most of the antiretroviral has been ranked according to their ability to get into CSF. And there's been a lot of work done by the Charter Group on how well that predicts efficacy within the brain, for example. Probably the most commonly used drug is efavirenz, and we know that gets into brain because it's got all sorts of CNS toxicities associated with it. So.
Okay, thank you, sir. Talking about the nanomedicine part of it, where you're developing the PDX model, like in case we develop a nanomedicine, it's now there are certain drugs which are sensitive to radiation as well. For example, temozolomide. So would it be feasible if a nano formulation is made with such drugs and bypass the blood-brain barrier so that you can reduce the amount of the drug dosage as well as make the cells sensitized for radiation?
I didn't get the question very well. You say if you combine radiotherapy with the drug, you could increase the CNS penetration?
Exactly.
Well, I mean, it is likely that you produce inflammation in the brain so that after the radiation, so that you let more drug get into the brain. But I'm not sure how early after the radiation you can start a new treatment with chemo, because probably both at the same time are too toxic. So that you need to consider. Maybe you can, we should address that question in preclinical experiments to see how early after the radiotherapy we can give the chemo. But I would say we are not doing that right now, and probably there is a reason behind it. We don't do chemo right after radiotherapy, even though there is inflammation there in the brain.
And in case of getting these nanoparticles across the blood-brain barrier, now, for example, you tag it with certain proteins, for example, say transcytosis. So what is the percentage of the drug or the nano formulation you expect to cross the blood-brain barrier in case you tag it with such proteins?
Well, you want me to predict what we will get? I don't know. I mean, it is so difficult. Sometimes when you look at the manuscripts or the published data, they say they improve the penetration of the drugs using these systems. But if you look closely at the data, maybe they got a 5-fold increase. And if 5-fold of 0.1 is 0.5, and if you need to achieve 5 to have a positive effect, you still need 10-fold more to go to the positive effect. So I'm very skeptical about these published studies. I think we need to do new ones to characterize better what is the real positive effect that we are going to achieve with these new systems. We are now starting a new project related to this topic in DIPG, one of these pediatric diseases, which is it is a brain tumor with a very well-closed blood-brain barrier. So we are trying to target the transferrin receptor with new peptides that have been developed by a Barcelona group. And we don't know yet what we are going to achieve. They work well in vitro, and then maybe it is published that they cross the blood-brain barrier better than the drug alone, but now we need to measure very well. And that's why I think we need to do these kinds of experiments with microdialysis and very, very specific experiments to know exactly what gets into the brain, probably not in the CSF, but also in the brain parenchyma, or better if we do it in both CSF and brain parenchyma.
Thank you.
Thank you.
Any other question? I have one question for Andrew. I wouldn't say that I'm skeptical about the long-acting parenteral administration for HIV, but my concern is that you still need to give 3-4 drugs a day, and we are solving this for 1 or 2. So the question is if you have any estimation of how much quantitatively the patient adherence to the treatment improves when you combine a once-a-month administration of one drug, while at the same time patients need to take 2-3 more drugs every day by oral administration.
I think that's, that's a key question, Alejandro, and it's it's one that the field is facing at the moment. What I would say is that these two medicines, they're the vanguard of this approach, right? So I think that they're the first two drugs, and I think that further development is required.
Because at the same time, one of the conditions that applies that the drugs need to be poorly water soluble.
Absolutely.
If they are water soluble, they will not work.
And the backbone to conventional therapy is the NRTIs, the nucleosides, which are very water soluble. So that's clearly an issue. What I would say though is that, and all credit to them, Janssen and ViiV Healthcare are currently working together to validate the efficacy of cabotegravir with rilpivirine as a 2-drug combination for maintenance therapy in HIV. They presented earlier this year in the Conference for Retroviruses and Opportunistic Infections some very encouraging data from the LAT-A2 study showing efficacy up to 48 weeks on suppression of virus with just cabotegravir and rilpivirine as a combination long-acting intramuscular depot. So I think we do need further development of other APIs to complement those that we already have. But it looks very encouraging at this moment in time, at least, for a 2-drug maintenance therapy which incorporates cabotegravir and rilpivirine.
Thank you. Any other question? Okay, so thanks very much again for joining us early this morning, and I wish you will have a successful meeting. Thanks again.